And we're back from our break. We have Ledge Council in here, and before we went to break, we had a couple questions, and I thought that it would be helpful if maybe Ledge Council could walk us through, um, pertinent things related to telehealth and consent. So, great. Take it away, Jen.
Good morning, Jen Carvey from the Office of Legislative Counsel. I'm going to put some statutory language up on the screen here. So the first one that I thought would be helpful to look at is in Title 8 in the health insurance chapter, because it's where we have the definition of telemedicine, also store and forward if you want to look at that. So telemedicine, and this definition gets cross-referenced in the statutes around the delivery of services through telehealth. Telemedicine means the delivery of healthcare services, including dental services, such as diagnosis, consultation, or treatment through the use of live, interactive audio and video over a secure connection that complies with the requirements of HIPAA. That's what the Health Insurance Portability and Accountability Act of 1996 is. People often interchangeably use the terms telehealth and telemedicine. As I understand it, telehealth is this broader umbrella that covers telemedicine, store and forward, audio only, telephone services, sometimes other services like remote telemonitoring, where somebody might be having their vitals measured over a distance. So we talk about telehealth. I would say the bill is about telehealth, but within that, we are talking specifically about telemedicine and audio only for purposes of what is being authorized in the bill. Store and forward, because we talked about it a little bit yesterday, is the asynchronous, so not at the same time, transmission of medical information, which could be video clips, audio clips, still images, x-rays, MRI scans, electrocardiograms, electroencephalograms, or lab results sent over, again, a secure connection that complies with HIPAA, to be reviewed at a later date by a healthcare provider at a distant site who is trained in the relevant specialty. And in store and forward, the healthcare provider at the distant site reviews the medical information without the patient present in real time and communicates a care plan or treatment recommendation back to the patient or referring provider or both. Our statutes often address telemedicine and store and forward together. For purposes of H84 and recording, we're really talking about this telemedicine one, the interactive audio and video, and also the audio only telephone. So I'll take that down for a sec, and then we'll hop over to Title 18, which is where we have two similar statutes to each other on delivering through telemedicine and store and forward, and delivering through audio only telephone. So now we are in Title 18. We're in 18 BSA 9361. And this is really directed mainly at healthcare providers delivering healthcare services through telemedicine or by store and forward means. And so I wanted to look at that definition from Title 8 first, because the definition used here says telemedicine has the same meaning as in 8 VSA 4098A, which is that section. So this first just authorizes, subject to the limitations of their license, a healthcare provider whose license in this state may prescribe, dispense, or administer drugs or medical supplies or otherwise provide treatment recommendations to a patient after having performed an appropriate examination of the patient in person through telemedicine or by the use of instrumentation and diagnostic equipment through which images and medical records can be transmitted electronically. And treatment recommendations made electronically are held to the same standards of appropriate patient care as in-person settings. Subsection C says that a healthcare provider delivering services through telemedicine must obtain and document the patient's oral or written informed consent for the use of telemedicine technology prior to delivering services to the patient. And the informed consent must be provided in accordance with Vermont and national policies and guidelines on the appropriate use of telemedicine within the provider's profession, and include in easily understandable language an explanation of the opportunities and limitations and sort of pros and cons of using telemedicine, informing the patient of the presence of any other individual who will be participating in or observing the patient's consultation with the provider at the distant site where the provider is, and getting the patient's permission. So somebody might be off screen, but in the same room and listening, so that information and that permission would have to be obtained. Assurance that all services the provider delivers through telemedicine will be delivered over a secure HIPAA-compliant connection. And then for services delivered through telemedicine on an ongoing basis, they don't have to go through the informed consent every time. They just have to get it at the first episode of care. So if it's going to be, particularly we talk about this in the mental health context, sort of an ongoing therapy relationship, the provider doesn't have to go through this every time if it's going to be weekly or bi-weekly meetings, for example. The provider must include the patient's written consent in the patient's medical record or document their oral consent in the patient's medical record. And then some insurers in particular have providers use a third-party vendor. So a healthcare provider delivering telemedicine through a contract with a third-party vendor has to comply with the provisions of the informed consent requirements to the extent permissible under the terms of the contract, which may be a little bit different. If the contract requires the provider to use the vendor's own informed consent provisions, then the provider is deemed to be in compliance with the informed consent provisions here if they adhere to the terms of the vendor's policies. And then there's certain times that a provider does not have to get a patient's informed consent to use telemedicine. So if there's a medical emergency, if they're doing the second certification of an emergency examination, determining whether an individual is a person in need of treatment. So this is a very specific mental health context for involuntary commitment, or for a psychiatrist's examination to determine whether an individual is in need of inpatient hospitalization. Again, this is in a sort of fairly specific and otherwise dictated mental health contexts. And then here's the one that we have been looking at. Neither a healthcare provider nor a patient shall create or cause to be created a recording of a provider's telemedicine consultation with a patient. This is the part you'd be amending if you move forward with H84. Then it also gives some rights to the patient. So a patient who is receiving services by, this one is store and forward. By store and forward means is informed of their right to refuse to receive services that way and to request services in an alternative format, which might be in person or telemedicine. And getting services by store and forward means does not preclude a patient from having a real-time telemedicine or in-person visit with the distant site provider at a future date. And originating site healthcare providers involved in store and forward must obtain informed consent as described in subsection C. So if a provider who's doing telemedicine with a patient is going to be sending clips to a distant site specialist, then they have to, the provider who is working directly with the patient has to get the patient's informed consent. There are similar but different provisions for audio-only telephone. I don't know if you want to look at those as well. There's just different considerations when doing audio-only telephone services.
Is the provision in audio only that the patient has the right to refuse services by audio only if they wish another?
Yes, I believe that is.
It's the patient's choice
Take a quick look at it
to decide whether or not they'll receive these services.
So again, we have the same definitions. Again, subject to the limitations of their license, the provider may, and this is for Medicaid patients to the extent permitted by the Centers for Medicare and Medicaid Services, because CMS will not pay for audio-only telephone in all circumstances. A healthcare provider may deliver healthcare services to a patient using audio-only telephone if the patient elects to receive the services in this manner and it is clinically appropriate to do so. So there are, I think, stricter guardrails around the use of audio-only. Provider must comply with any training requirement imposed by their licensing board on appropriate use of audio-only in healthcare delivery. There are the same or similar documentation requirements for informed consent. Also, the provider has to document in the patient's medical record the reasons the provider determined it was clinically appropriate to deliver healthcare services to the patient by audio-only telephone. So there may just be different considerations. For example, it may be more difficult to do a dermatology consult by audio only if there is a visual component that's necessary. The provider shall not require a patient to receive healthcare services by audio only telephone if the patient does not wish to. That's what the chair was mentioning. And then put some restrictions on a provider. Sort of can't be punitive if the patient doesn't want to do audio only. So the provider must deliver care that is timely, complies with contractual requirements, and not delay care unnecessarily if the patient wants to have an in-person or telemedicine visit instead. There's documenting the written, oral or written informed consent, similar to with the telemedicine. And then we've got the same language about, they can have services by audio only, telephone, in person, or through telemedicine to the extent clinically appropriate. That receiving audio only services doesn't prevent them from getting services in person or by telemedicine at a later date. Pros and cons of using audio only telephone, informing the patient of anyone else who is participating or listening and getting permission for that. And then there is a little additional information about whether the services will be billed to the patient's health insurance plan. There's been a lot of conversation about how does what's the difference between a provider answering a question over the phone or giving lab results over the phone that might not be billed to insurance and incur a copay versus having an actual visit that is by audio only telephone, and how could the patient know the difference? So whether the services will be billed to the patient's plan and what it may mean for the patient's financial responsibility for out-of-pocket costs, and informing the patient that not all audio-only healthcare services are covered by all plans. Again, if it's ongoing, they only have to get, for audio-only telephone, consent is only required at the first episode of care. If the patient provides oral informed consent, the provider has to offer a written copy. And then it's not required, informed consent is not required in a medical emergency. Those other two exceptions that were in the telemedicine statute don't apply. In this context, they're not allowed to be, audio-only telephone is not allowed to be used in those circumstances. It allows the provider to use a single informed consent form for all telehealth modalities, including telemedicine, store and forward, and audio only, as long as it complies with requirements in the previous section and this section. And then here's that prohibition on recording, creating a recording. That is the H84 language we've been looking at. And then this is specifically saying no audio only telephone for those two circumstances where it is permissible without informed consent in telemedicine, which is the second certification, and the psychiatrist examination for inpatient hospitalization, involuntary inpatient. Is that helpful? Hopefully.
Very helpful to me. Is that helpful to everybody else in the committee? Yeah, Val.
So several times I saw oral or written consent. That wouldn't be a liability, especially with AI. Can't AI recreate conversations with someone's voice that has been pre-recorded?
So to a large extent, this is all predating any kind of AI, does not contemplate AI. I think one of your members has been thinking about those issues for longer than others.
I have an answer for that too. When you do oral consent, usually you say, do you consent? And when they say yes, you write in the note,
Right.
Patient orally consented. It's not, AI isn't involved.
No, but I think the concern being raised is could somebody other than or not the patient personally be the one.
But then you would be talking to an AI pretending to be a patient, which would be a thing we haven't seen yet. Can you imagine?
Oh, Lord, let's not see it.
It's possible. There are some bills coming out that would prevent this, by the way. I will be sending it to the whole body. No, I'll be sending it to the whole body.
Not today. Let's not look at it.
Careful what you're reaching,
Was your concern, just not to invalidate it, is your concern like that someone might use an AI to trick a provider into thinking they're the patient? And
Especially with.
Then informed consent is probably the least of the concerns. I mean, there's some bigger concerns there, but yes, I mean, there may be a need for the provider to take reasonable steps to ensure that they are talking to the person that they believe they are talking to.
Like imagine
How do
something,
you know? I mean, if you have someone on the phone, I didn't even know that that was something that,
They do ask your date of birth, not that.
But it could
I
know
mean,
that.
That's easy, that's
But-
out there.
But you have to ask yourself, how does a provider even know if you're presenting?
That's true.
And from somebody who worked in a facility there were many people who presented themselves as someone completely who they were not.
Mm-hmm.
They all had various other names that they would use. I used to have a whole list of them.
I mean, when I
So-
call my daughter's, doctor's office, they really won't do anything over the phone.
Really?
You mean sharing the info with you?
I mean, if I speak to a nurse, she can say, yes, you should come in because your daughter has whatever symptoms.
Yeah.
But I don't, this is just something very new to me.
Have you done telehealth
Can
at all?
I had,
Okay.
can I give an anecdote?
Yes. let me-
I had the greatest healthcare experience in December. Thanks to our Leslie. I called my primary care on Sunday because Leslie looked at my finger on Saturday and said, "Ooh, you need to call your doctor."
Wow.
I got the on-call doctor to call me back. She went through this is all on the phone, went through the whole history, HPI, history of present illness, did a assessment of what I had, cellulitis on my finger.
Oh, sorry, that
And-
sounds painful.
And she prescribed an antibiotic over the phone. I went to the pharmacy 15 minutes later. It was 60 cents. She charged me for the visit, which she absolutely should have. She did a full evaluation in management. And then I took pictures of my finger and I uploaded them into my portal so that they had them. And my doctor ended up calling me back, my real doctor. Well, not that the other one wasn't a real doctor, but my personal doctor, she was the on-call. And checked out to make sure that, the antibiotic was resolving my finger. And I still have a finger today because, and it all
It didn't require
seamlessly-
surgery.
It didn't require surgery
Or the ER.
or the ER or even an urgent care.
Yeah.
And I thought to myself, this is exactly the way quality, accessible, affordable healthcare is supposed to be.
But did they
delivered.
follow up?
They followed up. Followed up 5 days later to make sure that my finger was resolving because they had the pictures
And it was a human.
and it was a human.
It was not a robot.
And
Oh.
not once did they see me other than a generic finger with a cellulitis on it. And I call, I give my name, I give my date of birth.
Did you get a patient satisfaction survey?
I think I did, which I didn't fill out. Anyways,
So much.
I guess and telehealth is dependent upon like why you're calling or when you're calling and whether or not they're going to do that, which is sort of the point of that, they make an assessment over the phone whether or not you need to be seen in person or.
And does it start with an initial visit in person?
No, don't have to.
Don't have to.
That was part of the language as well. There does not have to be an existing relationship between the patient and the provider.
I remember this really all took off during COVID.
Yeah.
Right? Like that's when we changed a lot of our laws to allow us to ensure people could still have access.
So can I ask you, when you first called,
Yeah,
you didn't talk to your regular doctor?
I talked to the on-call doctor who works in the same practice.
Okay,
Because they share calls. Actually, first I talked to the answering service who then pages. I suspect they don't have pagers anymore. They have cell phones.
and how much information did you have to give them?
I told them what was going on. She asked how it started. It was because I had gone to get my Christmas tree and I got a whole bunch of little cuts on my finger from Christmas tree. And I only knew that because I'd been squeezing lemons the day after I got my Christmas tree and it hurt. And it turned into
Sorry.
cellulitis.
And they gave that information to your doctor.
doctor.
Through all this, my question would be, how many other people or who else could have access to that information?
Same people as if you were doing it in person.
Right.
Yeah. So nobody else would pretty secure then.
all
I do have
portal.
Yeah.
Do you have like a My Chart with? Do you have a portal, a patient portal?
Don't think so.
I'm sure you do.
I'm probably so.
Access.
Yeah.
I do, but I don't have access to it. I never get on.
You have to sign up,
They are HIPAA compliant and HIPAA secure, which is why I was asking today
I'm
about
old
Teams,
school.
because I didn't realize Teams had been designated now as.
Oh, is it?
Oh, yeah.
And Zoom.
I knew there was a version of Zoom that was HIPAA compliant.
Yeah,
I don't know if all Zoom is.
I don't,
You have to purchase the.
I've been out of medicine for 2 years. Topper.
It's $200 minimum a month.
It's a lot.
I canceled them with Teams. Goodbye. It's like 60 a month, sorry.
Topper has a question.
I do this all the time. I'm the one that initiates the call. I call my doctor. If my doctor doesn't have to, if he's not on at that time, there's another doctor in the practice that takes the call. It takes care of me. But then I'm supposed to follow up with my regular doctor. And sometimes he calls me just to make sure everything's all right. It's pretty, I mean, I've never had a problem. I'm almost 87 years old, and no one's ever done anything wrong to me.
Oh, Lord.
Yeah, and I mean, I think the key is it depends on who you are and what you want, right? And your life circumstances. You don't have to do things by telehealth, but for some it works.
Like I said, it's coming whether we want it or not.
What's coming?
I mean, I know a lot of people here.
It's here. It's
To a
around
bigger-
us in this room right now. Listening to everything you said.
Yeah, so let's have Jen bring up
Yeah.
the bill as currently configured. We can decide whether or not, I mean, this is technically markup. I'm not sure if anyone has suggestions of how we can mark it differently.
Oh, yes.
Want to make sure everybody understands what we're doing.
We have a finding section.
Any committee discussion, and then I'm going to call for a vote. So,
Right, so this is H 84. It is the bill as introduced, and as we looked at yesterday, and now you have some more context for it, this amends those two statutes we looked at that talk about providers delivering care through telemedicine and by audio only telephone, to add language to the prohibition on creating a recording of the consultation, the telemedicine, or telephone consultation, to allow recording if the patient and provider both consent. And that's it. It's effective on passage.
that's it. Any discussion? Anyone have any questions at all about what we're doing? Make sure everybody's comfortable. Yes.
I just want to say, I think this is really important for our providers. I mean, this committee has done a lot of work over the years, helping with provider burnout. I think this is another good step.
I share many of the committee's concerns, other members around AI. But as the healthcare advocate said, the train has left the station or the horse has left the barn, and we're not going to stop that. And when we did these 5 years ago, this wasn't a thing. And I think this is important to our provider community, particularly our mental health provider community. And I think it's also really important in context of the Rural Health Transformation grant that the state received to be able to implement some of their ideas in using AI Scribe and helping community providers do that. They're at a disadvantage of costs with that. And
The other thing too is it helps the patient get services.
that's good.
Yeah, I mean, as nervous as I am about all the applications of the policy change of this bill beyond the bill, we can come to that, we shall perhaps may
May.
come to, may come to those things. Oh, some of those things, if we don't do it now, we're gonna have to eventually, but hopefully not in 5 years like this, but like when we first passed the telehealth laws, we hadn't hit the pandemic yet, and we literally had just done it. And then the pandemic hit, and if we hadn't, there would have been emergency provisions, but we were luckily prepared. Like, and within 1 week, I got sick with what we now believe to have been COVID, but for the first time. I was doing telehealth from home 3 weeks into the shutdown. It was like so quick, and it like revolutionized healthcare delivery. And so I think this, not doing this is delaying access to care to people at this point. So we need to like remove this barrier to access. And furthermore, this is also impacting workforce development. So I think for those two main reasons, I'm willing to support these changes despite my concerns about the bigger picture. But I really hope we make time this year to start addressing the bigger picture, because if we don't, we're gonna be back here in 5 years being like, oh no, now we have to do all these things and they're recording children's brains, so.
Do we have to talk about bot patients?
Nope.
There is, well, it's not related to this bill, but there is the generative AI right now. There is impersonating people is a thing, and it's getting incredibly sophisticated. And if you look, I don't know if it's in the AI healthcare bill, but there's other AI bills I'm sending out. One of them does say that if someone is using a robot to call, it has to say I'm a robot up front. So it would have to be like, I am Lori Houghton's like digital receptionist calling you to remind you of a meeting.
Wow, I wish I had one of those.
It exists now. I'm getting ads for it. I'm getting ads now
Wow.
for digital receptionists for my practice. Like when you call someone, it answers for you instead of a voicemail, and it says, hello, and it doesn't say who it is at first because it doesn't have to. So it says, it's your voice talking. And then if you push it, it says, I'm actually not Brian, I'm the receptionist. But it doesn't say that at first because it doesn't have to. So I think that's not in this bill. We're gonna have to come to that separately.
All right.
I support this.
Val.
Long story short.
I just feel if there are any issues that would surface down the road, that's life in many different areas, maybe every area of our life. And you deal with it as it comes, and you amend or change as you go. You have every person's patient's consent. I wish it was written. I'm not 100% comfortable with the oral consent. I would feel
That's
that
the
would close-
existing law, just, and well, maybe
Yeah.
not in this recording piece, but this is just about the recording.
Oh, I see your point. We could say unless they provide written consent. I mean,
And that's
it
my only
complicates it.
thing. Otherwise, I'm not even a computer person. I think it sounds advantageous.
Does that mean support it?
I do.
Okay, all right. I see your point though, because this could say unless the patient and provider consent to unless the patient and the provider consent in writing to the recording, but
That would be difficult to operationalize, I think,
Okay.
because they are not,
Okay.
because inherently they are not in the same location.
They may not.
So we could do it, but it would be, you're recommending against it because it would create complications that
I'm just-
unforeseen.
I'm just noting for you that that would require some sort of,
Yeah.
it would not allow the visit to continue
Mhm.
until there had been some sort of provision of a written material from the
Have an
patient to the
exchange.
provider. Right.
That's why I asked about an initial
Yeah.
visit. And I know that's not, especially in emergency, whatever, I just like an initial consultation with your doctor with a written would make me feel better, just because I think AI can do
Anything they want.
so much. I can't even talk of it, but we can.
Go ahead.
I work for Diva and we're, right now, it's going through legal where what's considered a wet signature.
What?
Yep.
Yeah, So when you do these, like if you are online and you're filling something out and you electronically, it's not considered a wet signature. So if you're gonna get into like, yeah, if you're gonna get into signing stuff,
Wow.
then you have to be really specific about what you're, you know what I mean? Like,
We could use biometric data, like you scan your eye to sign it.
you know what, I mean, it's probably more accurate.
We'll get, it's not this bill though, so
Yeah.
we could come to it later.
Any other questions? Concerns, thoughts? All right, I would entertain a motion that we move to discuss H84 as introduced.
I move that we vote on 84 as introduced.
Is that the title, an act relating to allowing telehealth appointments to be recorded with patient and provider consent?
Well, that we pass our committee,
Yeah.
that we vote. So our clerk is online. So for the sake of expediency, and unfortunately not able to vote on this as well. Because I learned from clerk that we haven't extended the remote voting to past calendar year 25, so it's not in effect for 2026.
Oh,
Yet.
I thought we had 3 votes.
It was only for 25.
So it's going back to rules.
Yeah, I think so. So, I've asked, Leslie if she would act as our, interim
Happy
clerk,
to,
and would the clerk please commence to call the roll?
Ryan Chena,
Yes.
Wendy Critchlow,
Yes.
Penny DeMar,
Yes.
Leslie Goldman, yes. Karen Leaders,
Yes.
and Deb's not
Did you
voting.
skip me?
No, because you wanted to go, you said last, oh, I'm sorry, I might have skipped you.
You
You
skipped
wanted the
Yeah,
top of the table
yeah,
last,
yes.
okay. Lori Houghton,
Yes,
I can't think of you as the top of the table.
I'm not.
Only,
No, not even a spirit.
Valerie Taylor. Daisy Rebecca,
Yes.
Barbara McFawn,
Yes.
and Alyssa Platt.
Yes.
So you still need
You still need,
to call her and then say she's absent.
I'll call it. Okay, so Deborah Powers, absent.
Laura used to be the clerk.
Long time ago.
Yeah.
Yeah.
Many moons ago.
Many moons ago.
All right, so the vote is 10, 0, 1. And Daisy is reporter.
Easy will be reporting.
And I need to know what to do with this, so you'll help it.
We need to report to the clerk's office, and then
And
Daisy
if you
needs
give
to
Daisy a
report.
list of witnesses.
Thank you, Jen.
Super.
And I anticipate this will be on the floor up for action, second reading on Thursday. Because today's Tuesday. Today's Wednesday. Oh, Friday. Sorry.
I was thinking, wait, what have I done?
I thought today was Tuesday, honestly. Okay. All right, let's move on. Thank you.
What day is it? Wednesday?
I just had this image of the former representative from Bristol watching us on
Oh, boy.
YouTube as we were doing, yes, our former longtime clerk. All right, so we are moving on to, I need to find clearly what day it is
Wednesday.
and what time it is.
Bill priorities.
Oh,
It's
the
a
priority.
discussion at 11.
Committee discussion.
Perfect timing.
I know. Okay, so I had Topper pass out, a list of bills that are on our wall.
Another one, I'm sorry, I left elsewhere.
Yeah.
We can do something, Deb.
This is Deb. Oh, great, thank you.
Sorry, Deb, we're using your paper. Government efficiency.
So I just want to say before we start this, because I wasn't here yesterday when this was passed out. Topper, Daisy, and I went through all the bills that are currently on our wall in committee. And I just want to say that there are some really fantastic, wonderful, important bills that are not on this list. And that doesn't mean we won't hear about them. It doesn't mean that we won't take testimony on them. But one thing that we talked about the first day of the session about what our priorities were for this session, I believe almost everyone mentioned something around affordability. And knowing what we are facing around cuts, federal cuts to our Medicaid program in the coming years. I just could not see expanding services when we, in a few years, may be faced with making some really, really difficult decisions around cutting services. So
Maybe.
if you didn't make this list, it doesn't mean you're not important. But affordability is the word of the session, I think. So anyways, does anyone want to, and I understand that this is just a list and it's the bill names and you may not know exactly what the bill is. If you have any questions about, not that we have Ledge Council here and not doing a walkthrough of any of this, but if we wanted to talk about like things that might be priorities for us. And Daisy, do you want to do, you're so good at the spreadsheets. Do you want to do sort of a ranking of like who gets votes and where priorities
Like
are?
track it?
Yeah.
Yeah,
Kind of
absolutely.
track what people,
Do you,
or do you want to start first?
we also considered when we were reviewing these bills that had already basically been, you want to explain it?
Oh, yeah, there are lots of, because we have a ton of things up here. A lot of these bills actually, we've already done. Several of them were companion bills in the Senate from last year. And so they're already, they may not have passed in the House bill, but they passed in the Senate bill. There's also a lot of bills where we took the bill and we incorporated that bill into another bill that we've already worked on. And I will say that there are several, I don't think we eliminated anything, but there are some things that the Senate is actually working on right now that I anticipate that we will be getting the companion bill from the Senate. So our session's kind of in two parts, House bills, and then we start working on the Senate bills that come over to us. Although I think we left those on here. But thank you for reminding me of that.
I don't want to go first because I want to set up this.
Okay, anybody wanna? Brian?
I'm sorry, can I ask a question?
Of course.
What's the C mean?
All right, we'll go first.
Oh, the things is a compact,
Oh, okay. Thanks.
there were so many compacts that I just thought,
Let's circle
let's put a C in front of the compact so we can easily identify them.
Thank you.
I thought it meant Carby.
Anybody wanna go?
I will go first if you
Go
want me to.
first.
My working memory isn't great. What did you say the process is you want us to do
Well,
again?
just like you rank like 2 or 3 on here that you
okay.
are really
Yeah.
interested,
But
yeah,
it doesn't, 2 or 3 priorities.
yes.
Okay.
Yeah,
So I would classify the priorities, like cluster them.
okay, is this your way of trying to get more than 2 or 3?
Except that when you hear me, you'll see it's not some kind of effort to circumvent the process, but rather be more efficient. Like there's an AI bill,
Mhm.
but there's going to be more AI bills. So what I would ask is that we take testimony on the AI bills as one unit and then see how we can piece the different policies together into some action on AI. So I don't think that's like a way to, because I think it'd be a waste to be like, my priorities are this AI bill, and this AI bill.
What do we have for AI? We've got 644.
And there's the one I circulated to you all that will be public soon. that-
Okay, so we don't have a number on that.
No,
yet. Okay.
and I believe there's another one out there someone is doing, because I
Yeah.
remember hearing about this.
Okay.
So there's at least three, so just to be fair, I think we look at the three and we see what's the overlap, and then we combine them into one, whether it's a committee bill or one of them makes sense to fit the pieces into.
Mhm.
So that would be my number one priority, because I think we're already too far behind on AI. And number two to me would be the incremental implementation of Green Mountain Care, even if it's unrealistic in its current form, that we need a backup plan. Maybe it's not even a backup plan anymore in face of the federal changes, and perhaps some kind of universal access, some kind of step forward with Act 48 makes sense right now. And there may be other bills, like there is the Universal Primary Care Program Bill, H-185. I think there was a new one that is coming in or came in.
H-680 is released today. I'm looking at
Is that another primary care access bill?
an act relating to primary care access
It's
reform program.
Yeah, so I think these bills, like, once again, it's not about wanting to pass multiple bills. It's like, let's look at the issue and see if there's some action we can take that addresses pieces of those bills. I know that even though I'm a big proponent of H-433, I understand that it's unrealistic in its current form, but if we could at least take testimony on it
Mhm.
and move forward with some action towards the expansion of this concept of a universal system, or at least universal primary care. And then last but not least, I would lump together the compacts, because it's been a policy of this committee to pass compacts as they come out. And I know that each one needs to be handled separately. But I don't want to have to say, like, I think that respiratory care is more important than dental, I think they're all important. So if there was a way we could do a few compacts this year, it would be in line with our pattern over the last few years of joining compacts. Thank you. Next.
Thank you.
Oh, and just for the record, anyone out there listening, it doesn't mean I don't care about the other bills. I do.
Yeah,
It's just-
that's,
yeah. Yeah.
that
just-
goes without saying
Yeah.
for everything. And I didn't mean to be flippant about, is
I don't
this
think you
your
were.
way of getting?
Yeah, I don't think you were.
It's just-
Yeah, I just want people to know that, like,
I completely
it's
understand
hard
what
to
you mean.
prioritize.
Yeah. Okay, anybody want to go next?
Happy to.
Yeah, go ahead, Leslie.
And so I'm looking at three, and I'm not going to count one of my three. I circled the 4 compacts. Is that important enough to take up? We've done many of them. It should be pretty straightforward and easy. And it does expand access to care. So it seems worth doing that.
Was there one compact in particular you were, or?
Know the impact of these different compacts. So there are 4. There's the school psychologist, the respiratory care, dietitian, and dentist, and dental hygienist. I don't know. That would require testimony to know which would have the most impact on the population. So I'd want to know that first, somehow figure that out. I have no idea how.
For our 2 new members, compacts are licensure, compacts multi-state. So if you're licensed in one state, which is a compact state, you can practice in the state of Vermont without having to go and get a brand new Vermont license because you have a compact license. So just to let you know, that's what a compact is.
So putting my compact hat aside for the second, I am interested in H-569, which is an APRN bill. Obviously, I have, I care about this, that it would actually, it seems to me, sort of put into statute what's already going on, but allowing APRNs to be recognized as primary care providers, and put into the hospital, not primary care, I suppose, but hospitalists, and put that into statute.
Leslie, is that your bill? Or there is a bill in the Senate, S-163, which is APRNs in hospitals. Is that the same
It
bill?
probably is. I wasn't aware.
Okay.
So that's, what was it? Did you say the
I
Senate?
think it's S-163.
163. I'll take a look.
Leslie, I didn't get the number of that.
569. So I am interested in, supporting and expanding nurse practitioner, doing what they're already doing, but making it in statute. I am also interested in 586, which is the facility fee bill that Daisy proposed. I went to the same conference she did, as she had mentioned, And I think that there's a lot of extra costs going into facilities that maybe don't need to. So I think an exploration of that would also reduce costs in the system. So that's one thing I'm thinking about. And I'm also interested in 583, which is the private equity bill. And I'm particularly interested because I think the private equity space is a lot in long-term care facilities. In my arena, in Springfield, Vermont, there is a nursing home that is a disaster. And people have been there and have had to be moved away from there because of the kind of care, and they're owned by private equity. And I think private equity is exploiting our nursing homes, or could be, and I think we need to know about it. So those are my three.
What was that last one? What number?
583.
583.
Oh, yeah.
I'll go.
Yeah.
I want to take up H558, the Medicaid School-Based Services Program. And I'm just going to do a lump recommendation that we hear anything that could potentially lower costs to Vermonters. Because there's a lot of
I'm glad you're advocating to add back in the ones that would increase costs for.
No, wait, no, definitely not doing that. Yeah.
I did not choose the Vermont prescription discount card program, even though I think it's great and we should do it, because I think we're already doing it, but maybe I miss.
Yeah. Is it tomorrow?
Yeah, I saw that we were getting.
I thought it was Thursday, but that was.
So that's why I didn't choose it, because I knew we were already doing it.
Sorry, and I will just add one thing. I'm curious about H585, which is toppers.
My number one choice.
I thought it would be. I'm curious about it. I wasn't saying I was supporting it.
There's some good stuff in that bill.
There is some good.
Very good
That's a
stuff.
good job, Topper
Yeah.
McBond. There's some
Yeah, I
good
did a
stuff in
work
that bill.
hard.
You did. Alan,
You know, I've been scratching so many years. I'm gonna back up Copper there on that number one, so health insurance reform. Number two, because I'm up in the area of, I want 8270 confidentiality for peer support counseling among emergency providers.
we're hearing on that this afternoon.
Well, still, and I think three, limiting facility fees for certain hospital outpatient department services, I think is important. And my fourth one was Vermont's adoption of respiratory care and interstate compact. Those are my four. And again,
Which one was the last one? I'm sorry. Respiratory thing.
and if anything else that don't cost us money. So I'm with you.
Figured you would be.
You knew that. Nick.
Karen, do you want to go?
Sure. I'm interested in those bills that are saving money. So things like, the hospital fees, prescription, which I guess we're doing already. I'm really interested in, expanding primary care and making that a whole subject matter that we really look into. And it's one other. Well, I don't know what it's about because I haven't looked at it. And I apologize. I should have looked at these things last night, but it has to do with transparency in.
What number?
Mental health
Let me just see. I think it might be 5.8. Yeah, 5.8. I don't know what that's about, but it's a subject matter I'm interested in knowing more about. So I'm just looking at the title.
Black hole. I didn't say that out loud. That's on the record. I'm sorry. Wendy.
I have to say, I did read, and I really, right, think it can be useful, it's H185. And I,
185?
yes,
Primary
Oh,
care.
yeah.
and I do like the 583. And I don't know enough about 573, is that yours?
Yes.
That's
the
a
one
little
that
elevator thing for.
kind of opens up the pathway for folks who are in a mental health crisis to get to the highest level of care. So it would expand the people who would be able to do that certification that they're in a crisis.
Okay.
Right now, physician assistants can't do it, but they're the ones that most often
So,
are available to do it.
okay, I like that one too then.
Daisy, do you want to go next? I think, oh, Val, did you?
I don't, I feel I have a lot of learning to do.
That's great.
I. Okay, I'm gonna ignore the fact that the ones that we have on our agenda, because I think that we've already started off the session with a really strong approach to what we're taking up, including the prescription drug card and, the EMT or the emergency service responder privacy. And I think, I don't know, I'm thinking bigger this session. I'd like to see us take up Topper's bill in terms of healthcare reform, because I think there are a lot of cost saving measures in there that are really sensible. And could have a major impact on the way that we pay for healthcare. But at the same time, I think I'm thinking bigger in terms of how we deliver healthcare. So I'd like to see us take out the issue of let's see which bill. The universal primary care or universal care. I think Brian suggested just having a general bill where a committee bill or something where we look at that, but I think there's never been a better time to really think outside the box with all the reforms that we're doing and payment reform as well. So that, and then AI, and agree with Brian again that AI is, we have several bills that are all really urgent around AI coming at us. I have one around mental health counseling to protect folks from chatbots. And that's probably my top priority in AI, but I do agree that there are other equally urgent topics in AI. So universal care, AI, and Topper's bill.
Which one's Toppers again, number wise? I'm sorry.
585.
It's a lot of pages,
Saw that, right on the tip.
a lot of pages.
Okay, I think that leaves me. I was gonna make a joke that if it was your priority, you just volunteered to report it. And Val is the smartest one in the entire. So in full transparency, you have a lot of people identified a lot of the bills around primary care and sort of coalescing them all and thinking of them as one topic. I will say that the chair of the Senate Health and Welfare Committee has introduced a bill around primary
Oh,
care.
okay.
And I suspect that we will be talking a great deal about primary care. And much like what we did last year with S-126, it is my hope that in the first half of the session before crossover, as we have time, I will be scheduling like just sort of subject, testimony on the subject. That I think that probably the latter half of the year will really be diving in. So I'm going to pepper in testimony throughout the year, so it's things that we can be thinking about. So letting everybody know that. What are my priorities? I forgot to think about this. Whoops. Because I didn't have Topper reminding me yesterday when I left. So I would say my biggest priority is H583, which is healthcare financial transactions. That's essentially corporate practice of medicine. I'm not gonna list any of the things that we're kind of dealing with right now. So obviously, H84, we already did that. We're gonna hear on H270. And H577, this stuff is already scheduled. I am H585, Topper's Bill is probably my number 2. No, my bill's number 1, number 2. I'd say mine and yours, but they're not. They're all of our bills, so doesn't matter whose name is on them. And I really hope that we can do some, we have H558, which is the school-based services. And Daisy has some, things around sort of, we talk in this, committee about practicing to the top of your license a lot. And that goes to the APRN bill that Leslie, you were talking about. So I'm hoping we can sort of deal with all of that. So I'm lumping them all together. And yeah, so those are my priorities. And so Daisy will sort of culminate this and we'll get. We have 4 compacts. And I will say it has traditionally been the practice of this committee that we love to expand coverage. However, I know that the Office of Professional Regulation is, and while they always support these, we do have an ongoing concern around the fees that they're collecting is not keeping up with the demands, and that compacts lower their fees that they receive. So that's always kind of the one overarching concern with compacts.
Is that a vote for compacts or no?
I'm not gonna put that on there, but maybe. I'm not sure how much we would have to, I don't know how much time we have, because while the compacts typically, I don't want to say they're easy or that they're no-brainers, because they're not. We do end up taking a lot of testimony on each individual profession. And while it seems like a lot, I mean, it seems to make sense to combine them all, to be thinking about all 4 of them at the same time, it means we're delving deep into 4 different professions.
Yeah.
And the ensuing testimony that all of that takes and the time that will take. And since I had a panic attack the other day of, oh my gosh, we're running out of time. Brian, and then Leslie.
Yeah, I hear that, and because it was one of my priorities, what I would suggest is if we were to consider pursuing any of them, that perhaps we find out the status of the compact before we dedicate too much time to it, or we do like an hour where each profession has 15 minutes to say, here's where our compact is at, and then we decide if we're gonna move forward or not. Because I know like with the social work compact, there was a short form, then it came out, then we found out it was forming and we got in.
Yeah.
And it was useful to do so, but there might be some like there's no rush to join it, or there might be ones that are well functioning and we're the last state.
Yeah.
And it might be like, why, let's do it, let's just get it done. Let there be dietitians in every state, or whatever, that can practice in every other state or whatever. So my suggestion would be, if we are gonna do it, we do like some kind of like update on where the compacts are at, and then decide so that we don't go down a rabbit hole and spend hours and hours and hours and hours to just do nothing.
Good idea, because you're right.
Yeah.
I forget that all of the compacts are at different levels.
And we could be the tipping point for one of them. And if that was the case, then I'd be like, let's do, an interstate compact on carrot salesmen or whatever. I mean, making something up so it doesn't indicate support for anybody.
Except carrots.
That's not in this committee.
The sponsors of the bills should be able to tell us, like, what is the workforce demand or potential impact of passing that? That would be a factor in my decision personally.
Or someone from their their professional organization reached out to the committee. Hint, hint, and said, here's where we're at. That might be proactive work that would then help us decide.
Leslie, I think you had,
Yeah, just a couple things. Yes, there is a companion bill on in the Senate. It's S-163 for the APRN bill. So,
163?
yeah, S-163. So it's the identical language. So I don't know if or where it might start. So just you asked, so I found out.
Everybody, read it.
I think so.
Except-
Could I? I'm not done.
I haven't done it yet.
I'm not-
Wait, you took
Topper.
yours.
Topper did not go.
No,
Oh, you said yours was your number one.
I do not have toppers.
I didn't do it yet.
Well, the fast one.
So I'm gonna do it right now.
All right, and then I
So
go
I was
after,
wondering why she said that now she's gonna calculate all.
so can I go after, come back after him?
Yeah.
Thank you.
Okay. See this one here?
Yes.
Okay, that's what my bill is on. And with complete transparency, this is the governor's bill. You probably all knew
Oh,
that.
never mind.
No, didn't know that.
No, don't get into politics. This is good stuff for them. That's number one. Number two is developing and implementing the universal primary care.
Is that the governor's bill as well?
No.
The
Uh,
next governor, maybe.
Depends if I run or not.
That would be great.
And my third priority is 583. Which is healthcare finance transactions and so
Oh. I made you number two and you made me number three.
on. Well, number two is the universal healthcare, which I've been pushing for years.
Since the invention of healthcare.
So anyway, I can't abandon those things.
Yeah.
What's the number of the second one, Topper?
185.
Got it.
So the governor's bill is which one? Because I'm going to read it in detail now.
585.
All right. I'm looking at it.
585.
I'm going to read it in great detail and take it seriously without judgment based on.
I think we should calculate all this.
Yeah.
The
Okay,
ones that come out on top, really look at them.
I'm still going to read.
And I will say that the Department of Financial Regulation put a lot of work into that,
Yes, they did.
To which one?
to 585.
Okay.
585. They put a tremendous amount of work in it.
Leslie,
So I'm just saying that I didn't pick 585 because I figured everyone else would, but I think looking at it and reviewing it is excellent, and the right thing. So thank you, Topper. I also just want to, this is a fourth for me, so I'm not sure I'm allowed. But I think the Medicaid based payment system is crucial and sort of want to
You already
flag.
have a fourth.
What's my fourth?
so this is the fifth.
That's your fifth.
No, I have four on my list. Don't take 585, don't count 585. Because I know what's gonna happen anyway. But I think the Medicaid school-based stuff is important. That should be my fourth.
Where is that crystal ball? I'd like to have that. Leslie, where is your crystal ball?
What am I looking at? My crystal
Oh, your
ball?
crystal ball there. You
Okay.
just said 585 is gonna happen.
No, it's gonna be taken out.
Oh.
It's gonna be discussed. That I felt pretty confident about.
So 558
There's
is
pieces
your
of it I like.
fifth.
Yeah, 558, I'd like to.
Some pieces I like, some I'm like, no.
So mine was 569, 586, 583, and 558, and I'm not including the comments.
Okay. All right. Any other questions? Daisy will kind of get all of this together.
You can plug it into ChatGPT and see what it tells us. You could.
How do we know though if it's our real priorities or if they're just bot
You
priorities?
have to review the decision. It's a human reviewed decision. You know,
Okay.
yeah, that's.
I like to do
All right.
it this way.
We're moving on.
Not the other way.
We're gonna take some testimony this afternoon on H270, so we were able to get Katie in to do a walkthrough.
Right on time.
H270, perfect.
Time for once. Like, you're on time, like. We're not like, oh, can we bump you 15 minutes? Like.
And thank you, committee, for your input on all of this.
Thank you for this process.
Should have seen some of the past processes. Like, there's one year,
Let me move.
where like there were these boards up and you had to put stickers, and there were people in the room following us, nagging us about where we put our sticker. You remember that? Yeah, it was like, this is better.
So we're being bumped away.
Yeah, take it away.
So much better.
I've been walking through the State House and I'm marking up pieces of art that I want to poach for
I
our
like that one.
committee.
I do like that one.
Oh, I was gonna change that out.
It's better than the old burning building one that.
Burning building is not
Can we
gonna.
get some robot one for this school, like something that a robot can be, some kind of like a brain with wires coming
Why
out?
don't you draw one up? We'll look at it.
Yeah, I will tell. Well, speaking of feng shui, there's cake taking up the middle of the table if anyone wants it.
He said there's cake.
There is one.
We-
Oh, Katie, no, I didn't. You can have some too.
Can I, Katie, do you mind if I do a procedural? We had, Tasha, we had discussion on BAA today. Where did that move?
Next week.
Okay, well, we're gonna be needing to move that again. Okay.
And I hope she.
Yeah,
We shortened it today so that we could hear Katie's well before the testing is happening.
yeah, we're gonna need to schedule that this afternoon because we need to get our recommendations to appropriations. Okay. Thank you, Katie.
I will.
Thank you.
Good morning for a little bit longer. Are you ready for me?
Yeah, we're ready.
Okay, great. Katie McGlynn, Office of Legislative Counsel. Let me share my screen. So this morning, we're doing a walkthrough in advance of testimony that you're receiving this afternoon on H270. Here we are, H270, which is an act relating to confidentiality for peer support counseling among emergency service providers. This is a bill that has been on the wall in various iterations over maybe the past 4 or 5 years. But the concept is that emergency service providers in their line of work may be exposed to maybe traumatic or difficult issues. Often there is counseling that is provided through their employer. And this bill looks at those counseling services and looks to provide confidentiality protections to what is said in those counseling activities. So that is sort of the overview. We start off with a list of definitions. I normally don't like to spend a lot of time on definitions, but I think they're important and relevant here. There's a critical incident stress management program that's mentioned. And then there's also, I'll go back up, but there's also a definition for a peer support counseling session. And I just wanted to talk a little bit about how those pieces fit together. So the program itself administers peer support counseling sessions. So the sessions are offered as part of the umbrella program, if that makes sense. So that is sort of how to distinguish in your mind between the two terms, but we can look at the language. The program, Critical Incident Stress Management Program, means a program established by the employer of the emergency service providers to provide counseling or support services to emergency service providers working in paid or voluntary capacity. And then who do we mean when we say an emergency service provider? An individual currently recognized by Vermont Fire Department as a firefighter, currently licensed by VDH as an emergency medical technician, an emergency medical responder, an advanced emergency medical technician, or a paramedic. Excuse me. Currently certified as a law enforcement officer by the Vermont Criminal Justice Council, including constables and sheriffs.
currently employed by DOC as a probation, parole, or correctional officer. Top of page 3, somebody who's currently certified by the Enhanced 911 Board as a 911 call taker or employed as an emergency communications dispatcher, providing service for emergency service provider organizations. And lastly, somebody who's currently registered as a ski patroller at a Vermont ski resort with the National Ski Patrol or Professional Ski Patrol Association. So that is who we're talking about when we say somebody who is an emergency service provider. We have a definition of employer. It means an entity that employs or oversees this provider working in a paid or volunteer capacity. So that's important because a lot of emergency service providers in the state are working in a volunteer capacity, including a state or local agency such as a county sheriff, municipal police department, Vermont State Police, or any state or local public body that employs or oversees volunteer emergency service providers. And lastly, we have our definition of the session. So again, the session is what is under the larger umbrella of the program that administers the session. So it means a critical incident stress management program session for emergency service providers who have been involved in a traumatic incident by reason of their employment or volunteer service. Subsection B starts, except as provided in subsection D. So we will look at subsection D. Both subsections B and C start this way. So they're laying out a rule, and then we're going to look at what the exceptions to the rule are. Any communication that's made by a participant or a counselor of a peer support counseling session of a critical incident stress management program established by an employer of emergency service providers, including any oral or written information conveyed during that session, shall not be disclosed to any individual by any individual participating in the peer counseling session. So somebody who is participating in the session can't communicate outside of that session, something that was conveyed. The top of page 4, similar language, except as provided in D, any communication relating to a peer support counseling session between counselors and staff members of the program, or between 2 staff members or more staff members of the program, including oral or written information, shall not be disclosed by any individual participating in the communication. And then we have language about the PRA, the Public Records Act. So written communications that are described in this section, like notes or records or reports related to the session, the counseling session, are exempt from public inspection under the Public Records Act and are kept confidential. Thanks. The Public Records Act exemption created in this section is not subject to 1 VSA 71(7)(e). So that is language about reviewing the PRA exemption every 5 years. Okay. Subsection C, you'll see we start in the same way, except as provided in D. So we're laying out the rule and then we'll look at the exceptions. A counseling session I should look at this. Any communication made by a participant or a counselor in a peer support counseling session, including any oral or written communication, such as notes, records, and reports related to the session, are not admissible in a judicial, administrative, or arbitration proceeding. Limitations on disclosure imposed by the subsection include disclosure during any discovery conducted as part of an adjudicatory process. But limitations on disclosure imposed by this section exclude knowledge acquired by the emergency service provider from an observation made during the course of employment or volunteer service, or information acquired by the emergency service provider during the course of employment or volunteer service that is otherwise subject to discovery. So an observation about the person's workplace, for example, wouldn't be excluded. But it's those conversations or notes that are happening as part of the counseling session that are protected. And then we get to D, which is our list of exceptions. So the confidentiality protections that were described in B and C that we just looked at shall only apply to peer support counseling sessions conducted by an individual who has been designated by an employer or a critical incident stress management program to act as a counselor, and the person has received training in counseling and providing emotional and moral support to emergency service providers who've been involved in emotionally traumatic incidents by reason of their employment. So if it's not a counselor that meets those two standards, then the protections don't attach. In subdivision D2, confidentiality protections described in B and C don't apply to the following information as it pertains to an individual designated to receive such information in the normal course of the individual's professional responsibilities. So protections on confidentiality wouldn't attach if there's any threat of suicide or homicide made by a participant of a peer support counseling session, or any information conveyed in a peer support counseling session relating to a threat of suicide or homicide. Secondly, it wouldn't attach, confidentiality protections wouldn't attach for any information relating to the abuse of a child or a vulnerable adult, or other information that is required to be reported by law. At the top of page 6, any admission of criminal conduct wouldn't be protected, and any admission of a plan to commit a crime wouldn't be protected. And then we have language that nothing in this section is to prohibit any communications between counselors regarding peer support counseling sessions, or between counselors and other staff members of a critical incident stress management program. So they're allowed to communicate with each other within the program to counselors. But it's when the communication goes beyond that. When I was looking at this again last night, I wanted to flag that this subsection and let's say B2, which also talks about the communication between counselors. I'm not sure if they're redundant or if they're trying to do something a little bit different, but we should, look at those a little bit more closely to see where the distinctions are and if we need both. Subsection F, an employer shall not be liable for any disclosure made in violation of this section by an emergency service provider who participates in a peer support counseling session. So if somebody who's part of the counseling session violates this law and shares something from the session outside of the session, it's not, the employer is not liable for that. That's it. Takes effect on July 1/25. Oh,
Or not.
right, yeah. Just kidding. It was introduced last year.
First edit.
I know.
First
I was gonna say, well, you definitely need an amendment.
Alan.
I don't think I missed it, but is there anything in there about the peer support being voluntary or mandatory?
It doesn't say anything about that. It's just if it's offered, these are the protections, the confidentiality protections that are attached to it.
Al, do you have a question? Oh, so, well, my question is, doesn't HIPAA already cover this?
To the extent that they're a HIPAA entity, so who is providing the care? Is it a healthcare provider? Like, how are we defining counselor? Is it hold on, let me stop sharing and go through this. So right now it's looking at somebody who's been designated by an employer or a critical incident stress management program to act as a counselor and then receive training on counseling and providing emotional moral support. So to what extent is that person a licensed healthcare provider that's falling under HIPAA protections? I'm not sure.
I'm just thinking that you don't have to be a licensed anything to still fall under HIPAA, because if you're, say, you're employed as a receptionist, you're still bound by HIPAA, but you're not licensed. So if you're designated as a peer support counselor, I guess wouldn't that fall under, or is it because the particular agency that would be contracting with you to provide peer support counseling, they're not actually HIPAA entities.
Yes, this is different
Okay.
than our peer certified.
Yeah, thanks for everybody for listening. Melissa's brain talk through
Different,
everything.
and that's why we have the folks
Okay.
come in to tell us about the
Okay,
services,
great.
but it's different.
Leslie, did you have?
No, that was my question. How is this different than other peer supports? And that's, that,
Yep, and Brian?
Yeah, I'm just trying to understand, so. This is saying that if there's a peer support group in an emergency responder setting. And that the information shared amongst participants
Mhm.
will be made confidential by this law.
Mhm.
How is it not already confidential, and how come only them and not other settings? And how could, like, right now, when group therapy occurs, the participants make an agreement to keep it confidential. Why do they need this in the law? Why can't they just all sign an agreement that what they, like, this feels like it's creating something extra for one population that I thought all populations already did, because it's part of the consent process of being part of the treatment or group therapy or whatever, that you're agreeing to confidentiality. See what I mean? So like, it's just.
Well, I was gonna say,
HIPAA aside,
I think
they're
it goes
agreeing
back
to it, you
to, these are not HIPAA.
Exactly.
And
But HIPAA aside, you're agreeing to it, you know what I mean? Like
Yeah.
if you, when you agree to do a group, usually you sign a consent form or you sign something like, you know, like an agreement or a contract, whatever you want to call it. And usually at the very least, there's on a board group agreements, and it's like, does everyone consent to these agreements? Like, well, what is said here stays here. And you say, yes, it's like a verbal contract. Why do we need it in law? And if we do, why are we only doing it for this population? Why wouldn't it be like an act relating to confidentiality for peer support counseling, period?
I think those are all good questions.
Okay.
I think one thing, you're having somebody testify this afternoon. I think one of the questions you might want to dig into is like, what is the nature of the program that's being offered and who specifically is hosting these sessions, and, what are their credentials? I think that will get you a little bit closer.
And I can ask them what I just asked you. I shall. I shall not, may.
Alan,
So I just want to explain a little bit. Up home, rural area, the biggest thing is fire department, ambulance services. They see some horrendous things. Okay, so when they go back to the fire station or whatever, they say, okay, we're gonna have a counselor come in. But then all of a sudden, you've got other people there that are your bosses that are hanging around listening to all this. So the confidentiality means, some of those people shouldn't even be in that room. So that's, in a small town, everybody knows everybody.
And like, shouldn't that also, aren't there like federal and state workplace regulations around
I
that
think
too?
there is, like in sheriff's departments in bigger, but the
You're
small
assuming Group
communities.
therapy, though, this also potentially could be one-on-one. I
No,
think
no.
we have to hear from the
Yeah.
providers.
Yeah, we will.
Good, that's right.
Yeah.
We have to hear from the
I think we have a
providers.
ton of questions,
Yeah.
and it all seems to be around, how does this work?
Yeah.
And I think that our witnesses coming in are really gonna,
What problems
Help us with it.
solving for who and why
Yes.
only this group? It could be, we did, if I may say this, like we did a bill one.
Yeah.
Early on in my time here, probably before Alyssa, Topper was in human services. Because this, when I'm thinking of, it was about mental health counseling for LGBTQ youth. And we were like, why are we only doing this for them? And we did it for all youth. So like we, in the test, we realized like, why are we only making a carve out for one population? So it could be that what comes out of this is we just do something for all peer support counseling. I don't know.
So I would just note the nature of the entities that these folks are working for.
What
They're
we're gonna
different,
hear.
right? Like, it's not an identification, like a personal identification that we're addressing, but it's people who work for fire departments and like pseudo government entities, right?
Well, I want to know why they need special protection that other people wouldn't get in their workplaces though.
I think everybody else does have them.
Katie, would you happen to, off the top of your, oh wait, I figured it out, Act 37 of 2021. I was trying to remember when we created the Emergency Service Provider Wellness Commission.
Yeah.
Okay,
What year was it? 21, you said?
21.
Oh, okay.
I remember that because I was sitting at my dining room table.
So I'm sitting here looking at the HIPAA definition of healthcare provider, because I think a lot of the questions are, do they fall in or out of the definition? So I think we would need to learn a little bit more about the organization to get a sense for that. I mean, it does say a provider of medical or health services, but there are a lot of caveats. So even though that long language is broad, I don't have a great assessment right off the top of my head.
It's so tricky. This was written before we certified peer
Mhm.
workers for recovery and mental health in Vermont. So I think the definitions are like now I assume we're talking about recovery coaches or certified peer specialists, but this is a totally different kind, so.
I mean, yeah, depending what you learn, or if it is somebody who's certified through OPR, you probably want to take another look at the language and integrate. Yeah.
I think we're gonna hear all about secure. I'm sorry, I'm just reading a report that they issued. Keep going. Go ahead, Brian.
No, I'm just wondering, and you may not know the answer to this either, because you just drafted it, like you might have just been following orders, so to speak, like, but like. Well, you know, because that's how it is, like, we tell Ledge Council what we want, and sometimes they just do it if it's legal, and they don't say, why are you doing it that way? So you may not know why, but I'm wondering why in the definition of emergency service provider, they have like firefighter, people, EMTs essentially, there's a few variations of that concept, but like it's DMT, EMS, EMR, E8, whatever, right? Then we have law enforcement, but then we have correctional officers as an emergency provider, but they are not just showing up in emergencies. They are watching over people day and night. So that's weird to me that they would be put in as an emergency provider. But I don't see crisis workers in here, and we show up at hotel rooms where people are overdue. We show up place like where people are on the verge of death, and we are an emergency service 24/7, and we only go when there's an emergency. So why is corrections in here but not crisis responders? I get why 911 call takers are in here, and I get why ski patrollers are in here. But so I'm wondering, like, who decided what an emergency provider was in this bill? Because that seems strange to me.
I remember vividly going over the list of every single thing, and who decided? I know you.
Not in this.
me.
No, this bill has its own definition though.
I think those people are.
I am curious whether it mirrors the commission. I would have to double check. And if not, it was written over a year ago, so I don't know. I no longer recall how the list came to be if it's not mirrored on the commission. So the commission was Act 37 of 2021. Let me take a look.
I do think it mirrors exactly the people that we consider to be emergency service providers.
Okay. So I have the list up from Act 37. We have, somebody want to cross-check it as I go through
I'm
it?
trying to find it. I did just find it.
You look at 270, I'll read Act 37. It says currently or formally recognized by a fire department as a firefighter, currently or formally licensed by a health department as emergency medical technician, emergency medical responder advanced. Yeah, this is the same paramedic. Subdivision C, currently or former certified as law enforcement officer by Vermont Criminal Justice Council, constable, sheriff, currently or formerly employed by DOC for probation, parole, correctional officer. E, currently or formerly certified by Enhanced 911. And that's it, no ski patroller.
Right, so they're adding ski patroller, so maybe we need to add in some other things too, to make it more accurate. Because it feels like it's not accurate to me, and it's just weird to me that someone who's there 24/7 watching over people is considered an emergency provider, but someone who actually goes to another category of someone who only goes to emergencies isn't. It just feels like a weird categorization.
I feel like somewhere along, because I'm looking at the current Wellness Commission members. And one of the members, the last one, is a member of the National Ski Patrol appointed by consensus of N and S Vermont Regional Directors.
Did we do a bill since then that amended Because there was another emergency service bill somewhere
Oh, no.
between 2021 and
Maybe
now.
we can ask our witnesses today. Where? Okay. Any other questions for Katie? All right. So I think we're done for the morning. I'll see you all back here at 1. Let's try to be back here right at 1 o'clock for our witnesses, because we are trying to squeeze something additional into our agenda, like to get through that before